Okay. Hello, everyone, and a very warm welcome to our Midwife Live Talk. We are so happy to have you here tonight, and especially happy because this is the first talk after a little break while Karen recovered from her hip surgery. So, Karen, we are very, very, very glad to have you back. And
Thank you.
yes, tonight's topic is vaginal birth after cesarean, or VBAC for short. For a long time, the saying was once a cesarean, always a cesarean. But thankfully, we know today that this is not necessarily true. And yet, many women still feel that once they've had a C-section, their next birth plan or birth path is already decided for them. So tonight is about understanding what is actually possible, what is evidence-based, what is realistic, and what women can do during pregnancy to prepare well for a VBAC. I'm especially happy about this topic because Dr. Grace Cheung, who is with us tonight, was my very own obstetrician for both of my births. My first baby daughter was born by a secondary or emergency C-section, and my second child, a boy, was a VBAC. So this is something very close to my heart, and I may share a little bit of my own experience as we go along. So let me introduce our speakers. We have Karen Siegler, midwife, who many of you already know. Karen brings decades of experience supporting women through pregnancy and birth and a very realistic and calm and encouraging view on VBACs. And we are very honored to have Dr. Grace with us. She is a specialist in obstetrics and gynecology here in Hong Kong. Dr. Grace is well known for being very supportive of VBACs and physiological unmedicated birth whenever possible, and she has an impressively low C-section rate. So thank you very much to both of you for being here. Before we start, a small reminder, this session will run for a maximum of 60 minutes. We'll try our best.
45 minutes, we
40.
try.
Okay. And the talk is being recorded, and the recording will be posted on our new Instagram page called Midwife Live Talk. Many of you have already sent in questions, which is wonderful and very helpful. So thank you for that. And please continue to post questions as we go along. You can do that in the chat box, or you can also, of course, switch on your camera and your microphone, and we will try to cover as many as possible. So let's begin. So maybe we can start with that sentence I already shared. For so many years, people said once a C-section, always a C-section. Dr. Grace, why is this belief still so strong in places like Hong Kong?
I think when it first started, it probably came from the States. But in Hong Kong, people still have this misconception because I think people get scared after the first C-section and they think they can't do another labor. And I think it's the opposite, is that there is not enough material or education on a VBAC that gives people this fear.
Mm. So their fear is not well grounded, would you
No,
say?
this is not a scientific proof at all. There's no
Mm.
research behind this.
Yeah. So interestingly, when I had my cesarean, I, for some reason, had that belief that I could only have maybe two or three cesareans maximum in my lifetime. Is that true?
No, again, studies have not proven that at all. Now, what is the maximum? Some people ask me, what is the maximum number of cesareans in a lifetime? Now, I've looked it up. In my own time, I think my maximum would have been number four C-sections. But I am aware people do go up to 10, and the numbers that we've been hearing has been 13. But every additional C-section would be more difficult, of course, because of adhesions and perhaps even more difficult pregnancies as well.
Mm.
So no,
Okay.
there is not a magic number that you cannot go above.
Mhm. Okay. And one thing that I hear again and again here from friends in Hong Kong, I'm not sure whether this is a similar topic in other countries, um, but there's this belief that a baby is maybe too big for a VBAC or physiological birth, and how should we as women interpret those warnings?
Big in terms of size. That's all
Yeah.
relevant, isn't it? It's relevant to the mother's pelvis, to the mother's build, her genetic potential. Um, this is not just for VBAC. I have many patients who do come for second opinions, and their primary obstetrician will say, "This is too big, and you need an elective C-section as well." And I think we have to put it into perspective. Now, um, in in general obstetrics in Hong Kong, in Southeast Asia, we take 4 kilogram as a high weight, and anything above 4 kilogram would be what we call macrosomia, big baby. Now, this is for statistics reason. For Western culture, we usually use 4.5.
Mhm.
But I do not think that uh, we should just look at the weight, because we should also look at the build of the baby, right? I always say, look, if this 4 kilogram is concentrated around a little tiny ball, then there's a big mass that you need to try and get out compared to a long baby, right? And with the same weight, you could possibly, the weight is distributed longitudinally. And so it's a very different thing to push out, or different mass to push out, right? So I think there's no such thing as too big, because you do have to look at the the mother who's the carrier and her pelvis and what she's like.
Mhm.
Yeah.
So, could you maybe go into a little bit more detail what like real contraindications would be that would rule out a VBAC? So if, a large baby is not really one of them.
Oh, on the top of my head, absolutely contraindications. I would say if you had a previous rupture of the uterus,
Okay.
those are very serious situation. Other things that would be indicative for C-section, like perhaps a breech delivery, or a breech presentation, or placenta previa, these we would go to a C-section anyway.
Hmm.
But I would say if your uterus had a previous rupture and you got pregnant, I would not hesitate to advise you to have another straightforward C-section. Yeah,
Hmm.
yeah,
Okay.
yeah. And this
And
is absolute. This is
yeah.
absolute. Yeah.
And are there any like medical criteria that make someone a very good candidate for a VBAC?
When
Or
I
could
assess,
anyone try? Could anyone
mm,
try, basically?
okay. So we come to the discussion about how to assess someone for a successful VBAC, because this is a conversation I like to have with each individual. And the very important is, why did you end up with a C-section in the first place?
Mm.
What are the factors that contributed to it, and what happened? That's very important. The medical history, and sometimes I have to, when it's not it wasn't my delivery in the first place. It was easy in your case because I didn't have to unravel anything. I knew what I did, and I knew what chances we could take. But sometimes when you have the C-section elsewhere, as a doctor, I need to try and figure out what really happened.
Mm.
Yeah.
Okay.
And that's very important to give you then. I don't know whether you recall, but we always would have that conversation to say, look, Anna, we're facing this VBAC. What are the odds, and what are, what are the numbers? What is the chances of a successful VBAC? And then the client usually then decide. Yeah,
Mm.
yeah,
Okay.
yeah. Mm.
So one of the risks that always pop up when you look into VBAC is uterine sure. Maybe you can explain a little bit how big this actual risk of a uterine rupture is and how women should understand this number realistically.
Okay. Now, uterine rupture, let me just get it right. It's not the scar that you see on your tummy. All right. That
Okay.
scar very seldom ruptures in
Mhm.
pregnancy. It's actually the uterus one, so internally the organ. And the chance of that happening is the highest during a contraction. So it's actually during labor because
Mhm.
there's a lot of strength that's happening when you're contracting.
Mhm.
And things that are associated with higher, oh, going back to the numbers, yes, the common number quoted for uterine rupture during a VBAC is 0.5% to 1%. And this is for the most common type of C-section, which is a transverse scar, a horizontal scar. Now,
Mhm.
about 0.5% of patients may have, or some people have what we call a longitudinal scar. And it's not to do with what you see on your tummy. And we call it a classical C-section. And so it's very important as a patient to know what kind of C-section you had before, right? Because as a doctor looking at your scar, I wouldn't know what happened inside. Okay.
Mhm.
And
Okay.
so for some of our listeners, if you do go to hospital authority for delivery, they always love to try and get your previous records. Whether it's you've had some surgery done to your uterus or your previous C-section record, because they want to have a look what went on there to advise you further. So in our most common C-section, the scar rupture is about 0.5 to 1%. And what will increase that risk would be one thing is the interval. So when you have one baby and the next one is a VBAC, anything that is too near, and when we're talking too near, the studies say less than 18 months, then the risk increases. Okay, that's number
So
one.
18 months between labors or labor and pregnancy? No,
Labor
between
and the
labors.
VBAC. Yes, and
Yeah,
the
got
VBAC.
it. Yeah.
Yeah.
Okay.
And the second thing is induction. So when we're using medication to increase the contraction, and remember what I said, there's a scar there. And so what happens is during contraction, there's an immense force on it. And the weakest part, of course, is the scar. And therefore, with induction medication, it increases the risk of induction. Risk of rupture.
Mhm. Okay.
Yeah.
All right.
Hmm.
Um, Karin, maybe you can give us a little bit of insight. What do you think? Why do so many women feel that their VBAC chances are low, even though, from a medical point of view, they might be actually quite good candidates?
Mhm. I think that there is not a very good support on VBAC. So if you think about you're pregnant the first time, second time, and you just go with the flow and you're focusing on a vaginal birth, you have plenty of option joining antenatal courses and classes. If you think about having a VBAC, there are very poor support around. So I actually don't know many midwives who offer birth support or antenatal classes for VBAC. So the support is not there, and then so they're not prepared for VBAC, not from midwife side, so not from our side, unfortunately, but I think it's really a pity. And then, there are not many obstetricians who really support VBAC. I know Grace is one of the few in Hong Kong. There are some, but not so many. So you need to be really, really strong, really convinced this is what I want to try. And you always have the feeling, but if something goes wrong, then it's my responsibility. So many couples are afraid to go for the decision. And I think Anna, we have a question in our chat group who is actually pointing straight to this topic. So I would love to have a VBAC, but I'm so scared of doing the decision. And I have the feeling this is all on my shoulders because I don't have a team around me. Where are my people supporting me? Maybe the
Mm.
husband is saying, trust your doctor. She knows and he knows best what is correct. But do I really trust my birth team, which I have around? Or do I have the feeling they push me into vaginal birth or C-section birth? It's not something common. It's common to have a vaginal birth and it's common to have maybe an elective C-section. And it's common to have a secondary C-section, but it's not common to have a VBAC. So I have not much support around me, not from midwife, maybe also from doctor, it's a little bit reluctant. So that's not a very common thing, unfortunately. And I would wish there would be more support on from hospital side, antenatal courses for VBAC client. What you need to know about a VBAC and have an open mind about a VBAC and not just doing this decision. I'm afraid of doing something wrong or going into the opposite decision.
Hmm. I also have a lot of friends who had a C-section the first time, and then when they were pregnant the second time, I asked them, "Oh, so what's your birth plan?" And they said,
Yes,
"Oh, yeah, a C-section, because at least I know what to expect." And it's
what to
a bit
expect, and
scary to
people are
go
afraid.
into the
Yes.
unknown. It's scary
And
and
it's,
yeah.
I think many pregnant women have the feeling if I decide to go for a VBAC, then it's my decision. I don't have any support. So I don't know, Anna, how was it for you when you decided, okay, for my second baby, I want to go for a vaginal birth? Did you feel well supported? And was it a difficult decision for you? How did you end up going for, sorry, microphone, how did you end up doing this decision? You could also say, no, I go for a C-section again.
Hmm. I think, I think Yeah, I think there's, some really awesome benefits to having a physiological or vaginal birth, and I really wanted to do it. And at the same time, I knew I had a good team. So I had Karen by my side, I had Dr. Grace by my side, and you embraced it and you encouraged me along the way. It was totally my decision, but I felt like I was in good hands. So, probably choosing your healthcare team wisely is one of
Supporting.
the ways that you can feel empowered going into a VBAC. Um, yeah, yeah,
I just want to chip in that. I think it's very important for the mindset of the patient as well, because you're going into something that you need to be committed to. And you need to have a very clear mindset that you want to do this. And I remember for you, certainly, you were quite focused on this, but also having realistic expectation that it could, of course, end up with a repeat C-section.
yeah,
But I find those people that are most committed, and I'm not saying without any knowledge, but just to be embracing it, to going in with a supported husband, a supported midwives, supported hospital, and of course the obstetrician. I think our point, my bit is the easier part because I just say yes, let's go. But for as Karen just pointed out, sometimes that decision weighs heavily on the patient because there will be noises from everyone going, "Are you sure? Why are you doing this?" And so on. And yes.
yeah.
Mm.
So, is there anything specific a woman can do to prepare for a successful VBAC? If there is if it's a lot also about the mindset and the preparation, what is it a woman can do to prepare for it well? Maybe
Yes,
Karen,
this
you
Wait,
want to answer
Karen
first?
first.
okay, I start first. Yes. I think the most important thing is to understand why was there a C-section at the first place. So understanding that and accepting that and not having the feeling, oh my God, I was pushed into that. I had a traumatic experience. I don't understand and I don't want this setting again. And that's why I will decide to go for a vaginal birth and everything will be easy. So I think the first step is that I completely understand that why was it necessary to go for a C-section. And there are always medical reasons for that. And there is a reason why the decision is good and why it's good it went this way. And once I can fully accept that it was related to this baby, to this pregnancy, and now with the new pregnancy, I mix the card news and I can start new and I have the best support team. And I think for a successful VBIC, and I know Grace has the same opinion, it is so important trust your team and your support team. And the support team, this can be either if it's public system or private system. But if I have the feeling that is will my doctor support me in my decision? Because what I sometimes realize as a midwife, that couples sometimes come and say, but I don't know if this is really necessary. Maybe they're just pushing me into something. And people are really skeptical and they question that. And this is not a relationship of trust. And if my doctor recommend me to do this and that, then you can ask why. So, you need an explanation, but the trust is what is extremely important. So finding peace with the first birth is one of the most important things, understanding that, and then again, preparing for VBAC, getting the right support. And the support, for example, is that I really understand that like every childbirth, this childbirth can also happen to become a C-section again. And then I didn't fail, and I'm not frustrated about. I'm very grateful that we have this option. Hong Kong is one of the safest places in the world giving birth. And having this option in my background, something is maybe not going the right way, I'm very happy. It can also end up into a C-section. So being open-minded into both directions. And this is sometimes missing in many antenatal classes. The only right way of giving birth is I'm a hero if I do a vaginal birth, and if I do a C-section, even if it is later on an emergency C-section or for other reason, I have failed. And this understanding of birth sometimes is not good and puts pressure on women's feeling guilty afterwards. I haven't done a good job. Maybe I should have done this and that. So this is one thing. And when I prepare a couple for VBAC birth, I always also discuss with them doing a birth plan. It is very important. And also in this birth plan, you should write down what is important for me to have a gentle C-section. In case it will end in a C-section, nobody knows. It doesn't know, your doctor doesn't know, your midwife doesn't know, nobody knows that. So if all the support will end up in a healthy and safe C-section, what is important to me to feel I'm still okay and I feel in control, and what was maybe in my previous birth not so good that I have the feeling, no, I don't want to experience this again. So really thinking about, I want to have this different, better explanation. I want to lower the screen. I want to see the baby. It was not enough skin to skin contact. I don't know, but there was something. And this is important to write this in a birth plan and prepare for both outcomes, vaginal birth and for a C-section. And I think this is a very important topic. Yes, and getting a good support team. This is the most important thing. From hospital side, I wish there would be more support also from the private system, from the public system, supporting those women having a VBAC. Yes.
I have a question for you then. For women in the public hospital system, because I don't go there anymore, what would you suggest how they can prepare then?
I think the preparation is always at home. And if the first baby was born in a public hospital, then many times they don't have the chance to talk with the doctor to talk why was the C-section necessary, because as we all know, they are extremely busy at Queen Mary or at other public hospital. They don't have enough time talking to the couple, to the parents, and sometimes parents go home and they don't understand, yes, it was an emergency C-section, but I don't know why. And so I think the information is missing, and sometimes it would help if, for example, they can request the file and maybe go to a private doctor or go to a midwife and go through and ask for medical explanation. Because if I don't have facts and if I don't have a medical explanation, I believe it's my responsibility. So I haven't done a good job, and this is why it ended up in a C-section. Maybe I was too big, or I accepted an epidural too early, or I don't know. And if someone can explain me what is written in the file, because it is a language I don't understand, then I can accept that. And I think this constantly talks to everyone at hospital. I would like to have, and I want to try for a VBAC, and please support me in my decision. This is something that is crucial. And besides that, getting prepared at home on private levels, and not just the antenatal classes from public system. because there are no VBAC support there.
Yeah, because if you're in the public system, you might not see the same doctor twice, right? So
No. So,
I guess
and
having it in your birth plan and then maybe for your
yes.
birth partner to also advocate for you and to help communicate your wishes, and so to make sure that the team on duty understands and can
Mhm.
respect them. Yeah.
And you spend also a little bit more time in at hospital. So when I support a VBAC, as you know, I usually visit my client at home when they have a water break, when they start with contraction. I come with a monitoring CTG. I check them at home. So usually, if it is if it's a vaginal birth or normal birth and not a VBAC, I usually stay a long time with them at home. And if it's a VBAC, usually I go definitely earlier to be on the safe side. I go earlier to hospital with the client. So in public system, you will also spend more time at hospital. So being prepared, my husband knows what's coming up. What is the situation? There's times the midwives are always there, but they're not always with you in the same room.
Mm.
So, feeling not helpless and overwhelmed, and is this okay? So getting knowledge to feel in control, I think it's important.
Mm. And maybe a question for Dr. Grace. If I'm still in the process of maybe choosing my healthcare team and I have the means to go through the private system, what are some of the questions that I should ask my doctor or my healthcare team to understand whether they are truly VBAC friendly?
Right. So when we're looking at the provider, I think I will separate it into the doctor,
Mhm.
the midwives, or the hospital as well,
Mhm.
because this is very important. Now, often in the private system, the doctor has a team that works with her, and not just me. I always say, look, when we go through successful births, it's not just me. Actually, behind the scene, there's a lot of people that I have engaged to make it look good. And this includes a good anesthetist, as someone who's standing by for us all the time. This includes a good pediatrician who's happy to be readily available for us. And then the questions that I think we should pose to the doctor, first of all, just being honest and say, what are your thoughts on VBACs? Okay. And some will tell you straightforward, we don't do them. And that's fine. Because if you don't do them, that's it, right? Then you understand.
It's honest. Mhm.
Yeah, it's just nice and honest. And then you can also say, ask them why. All right. Then there are ones that say yes, maybe, how, and that, and then you can explore a little further. And then the questions come just like what we discussed before. When would you induce? What are your thoughts on induction? What are your thoughts on if the baby didn't come at 40 weeks or 41 weeks? What do we do then? And how can I minimize my chances of having a repeat C-section? Having a genuine, honest conversation. I think even in normal vaginal deliveries, you want a conversation. You want to feel comfortable, like Karen just said. You want to have a trust build up between you and the doctor. And to be honest, it's not just one way; it's both ways. Because when I take on a patient to go through a VBAC, I also want to feel comfortable that she trusts me, but I also trust her, because when we make decisions, it's a two-way thing.
Yeah. So we actually had some of our community submit some questions before, and you kind of brushed on them. So one of them was, if my first labor failed to progress, what is the likelihood of this recurring?
Just me, right? It depends. Again, the history is very important. What happened? Were you induced? How many weeks were you? What happened during the labor?
Mm.
Um, how big was the baby? How far did you get to? Was the oxytocin used during that first labor? Yeah. And what eventually pushed the doctor to do the C-section. Yeah.
Mm.
And I think it's a case by case. I think we can't, there's no one answer to that. I wouldn't dare to be able to commit to that unless we know more facts
More.
about that one. Yeah. I think one thing we might want to talk, I don't know whether it's now, it's the induction of labor. People like
Yes.
to ask that. That's, I think, a
Yeah.
very important thing, because I did mention that induction can cause higher risk of C-section, repeat C-section, or uterine rupture, sorry. So what are the induction methods that is possible and safe in a VBAC? I would say if you consider a cervical sweep, and now that's gentle enough. A cervical sweep is not and it's not a medication. And what we do is when your term and the cervix is ready, we do a vaginal examination and we actually sweep the cervix, the membranes of the cervix, and promote hormone production. And that's quite a safe procedure to do. And also, you could ask your doctor for that. Second induction methods that some people also use is a catheter, the Foley catheter, because it's a mechanical thing. So it doesn't cause you extra contractions. So a catheter, or it's called a Cook catheter as well, you put it into the cervix and we inject a little bit of water into to dilate the balloon. And that mechanically can cause dilatation of the cervix. And you hope then the contractions will follow. Okay, so that is also a safe method that possibly can be used. But then we come to the medical side, which is the Pitocin that we're talking about, or the oxytocin, which is a similar thing. Now, in the past, we have had that used before, but we have to be very careful with that because, as previously mentioned, the contractions can be too much, and we have to watch the fetal heart. And so we have to have experienced people know how to titrate that if we go down that route. And this is also something, is a discussion that you can have with your obstetrician in terms of induction or not, or how far do you go with the induction? Yeah.
So one of the questions that were submitted before was my first baby was 3,660 grams at 40 plus 8. Would you recommend an earlier induction to increase likelihood of VBAC?
Oh, for me?
Yes.
Right. So last time you were, sorry, what was the number again? 3
It was 40 plus 8, and
yes.
the baby was 3.66 kilograms.
Right. So the question goes back again. Why did you need a C-section? What happened? That's my question first. 3.6 in Hong Kong, or certainly for Westerners, is pretty average, I would say.
It's not particularly big.
It's not particularly big. But the other thing also, remember, it's not just a weight. We also would like to know the baby's head. Because if the head can't get through, you have a huge head and you only 2.9, you cannot still deliver the baby. And then note that this patient went past post-term. She went to 40 weeks and 8 days. Yes, difficult to say. We need to go back to what happened there. We cannot just say, oh, look, if we did it at 39 weeks or 38 weeks, the only thing we can say is most likely at 39 weeks, the baby would have been lighter and smaller. That's all we can say. Yeah, but no, we cannot. I wouldn't recommend it just based on that weight or gestation.
Okay. We had one more question from a listener who was asking, I'm planning a VBAC in Matilda Hospital, for anyone who's not from Hong Kong. That's a private hospital here. If baby doesn't come by 41 weeks, is induction safer, or is it better to just plan a C-section?
Now, first of all, I think Matilda is a very fair place to have a VBAC, because I have found personally the midwives to be quite encouraging and having the patience to wait for patients to deliver. Now, if you look at 41 weeks, most people say this is post-term now, whether it's a C-section or not. You're in the field of discussing whether we should have an induction. The question again goes back is, would this induction help me to have a successful C-section, a successful VBAC, right? So we're going to assess and go back. Why did you have the first C-section in the first place? Second of all, what is this weight of the baby and how big and what's the pelvis of the patient? So again, I don't think there's a clear answer for that. But at 41 weeks, when things are not happening yet, or the cervix is not favorable yet, then yes, we tend to be more on the side of probably repeat the C-section than going against the grain. I love to have deliveries that just pop out. Even with the VBAC, I think that was the case with you anyway. You come in and you in labor yourself, and that's as natural as it gets. And I stand there and literally receive your babies. And that's the joy of me, my profession. When I need to interfere, that's not as great, I think. Right?
And I also have to add on, it's many times VBACs, they go so smooth and so straightforward, and you're surprised. And if you ask about the first childbirth, they say, oh, it was hours in labor and the cervix didn't open up and it took so long time. And then, the VBAC is just doing like really straightforward. And this is really nice. And I think many times either the VBAC is working straightforward or it's not working. But it's not that many times it takes, out of my experience, like long time, and you have to interfere a lot and this and that, what you would do, if it would be the first baby. So many times it goes very straightforward, like in your case, Anna, it was also, like very straightforward. And I think our next Zoom talk will be a positive birth story talk. Yes. And it will also be a talk about vaginal birth after C-section, what fits perfectly to our talk today. So I'm very happy that Maria is joining this talk, and she will.
So in 2 weeks'
time. In 2 weeks' time.
Yeah.
So I think it was also like your birth, very straightforward. And I think sometimes I would like to encourage women who are thinking about, I don't know, I think we have this nice question in our chat group from Miral, I hope I pronounce it nicely, who is 1 year postpartum C-section. And she's terrified about a VBAC. And to address these questions, I would like to ask, what makes you terrified? What are you terrified of? How is the communication with your obstetrician? Who is supporting you? And I don't know. I think it's a common fear. If you ask women, why don't you want to have a VBAC? Women said, because I'm afraid that it becomes a rupture. And as Grace mentioned it, most women believe it's the scar, the one you see outside. It's bursting and it's tearing apart, and then I don't know, whatever you have in your mind. But it's not a case. Many uterus rupture are actually very silent, very blind, very little. And it doesn't mean this is good, but I'm just explaining this is not something women expect something dramatically to happen. And this is usually not the case. So if women are terrified of a VBAC, first I ask you why and what am I terrified of? And maybe there is a explanation, a medical explanation, or the support system which helps me going there. And I don't know, I never had the experience supporting VBAC parents that during labor they think about, oh my God, it may rupture, or what is with my scar? I don't know, Anna, did you think about that while you were in labor? Or
no.
You were just thinking about it's a normal labor. You're just in labor, like with the first one. And I think giving it a try, if there is no medical reason speaking against this decision, you don't need to be brave or not brave. You just try. And the same like with your first baby. First baby, you just go with the flow. And the second one, if your doctor is supporting you, also just go with the flow and see what's going to happen. And you can change your mind anytime. So I think you're in best hands in Hong Kong. Yes, I think. Yes.
Yeah, Lily, do you want to unmute yourself? You've raised your hand.
Yes, hi. Yeah, maybe just to share from the perspective of someone that doesn't have any medical background, and as one of those women that is scared for natural birth, because in my case, I never heard about VBAC until I came here to Hong Kong.
Mm.
Like, I'm from Mexico, and that was a term I've never heard about in the past, even with women like friends or women in my family, like my cousins that had kids years ago. They were all C-sections because Mexico, it's very prone to making C-sections. And like, I remember nobody, as they had kids and one after another, C-section, like nobody really talk about why, or like nobody asked. It's just like, because I think for a lot of years, that was the belief that after a C-section, you couldn't have a natural birth, and everybody accepted. So for me now, it's really hard to even question that like, oh, you can, because now, like, even when I talk to my parents about it, they're like, no, but you cannot, because there's this belief, that they still, and I'm like, no, I've heard about VBAC, and nobody knows what that is, like, at least in my family, for example. So yeah, that's something I'm very scared about, because I only have one kid now. My first pregnancy was obviously a C-section because my baby never turned to the proper position. And so yeah, I don't know what are the chances if I get pregnant again, if that's something that could happen again. And if not, if let's say like the second baby really turns the way it should turn, then it could be then, from what I'm hearing, a successful VBAC, because my first baby was not the weight was normal, I guess. It was like 2 kilos, 500 grams. And yeah, the only reason because it was a C-section is because it never turned properly. And last time I checked with my doctor, she said that the internal scar was okay, whatever that means. She only said it was okay. So yeah, I don't know, like, if there's something that could happen again, that it doesn't breach, so I have to be a C-section again, or there's like high chances that I could have a VBAC next time.
Right. So I think your question is whether this baby is going to be breech again. All right.
Yeah.
Yeah.
And because
So
that would be something that then I wouldn't have any option. It has to be a C-section again, right? I wouldn't
most
have the
likely.
options for a VBAC.
Correct. So in a proportion of people, they tend to always carry breech, and it has to do with their it could be something to do with their spine as well, or the way their uterus is, that the baby can't turn. However, your uterus has been stretched once already by the first baby. So therefore, there should be it should be more roomier to be able to let that baby turn. Now, as long as this baby is able to become cephalic first, the head down, then you actually stand a good chance of the VBAC, because it's not a repeat problem. You know what I mean? The reason for your C-section last time has already been solved once that head comes down. So it's likened to a first labor again.
Okay.
So it's simple, it's solved. As long as, of course, that was a straightforward C-section last time, and it wasn't complicated by funny scars or infection or anything else. Yeah. So
Okay,
your battle most likely is waiting for that head to come down.
Yeah.
Yeah.
We'll have to see what happened.
Yeah.
Karen, I have a
Thank you.
question. Thanks, Lily. Karen, I have a question for you. One of our listeners submitted a question before the talk, and I think that's also maybe one of the contributing factors why women might choose a planned cesarean. She's asking, if you try for a VBAC and then end up with an emergency or secondary C-section, is the recovery harder than with a planned C-section?
Yes. I don't think so. It's harder. So the thing is, if a VBAC ends up in a C-section, the feeling of I failed again. Maybe I shouldn't have tried it all. It would have been the better decision not to go into labor at all. And I think many times we forget that birth is not just pushing out a baby through a vagina. Birth is actually a process of your mind, of your body, of your hormones, of so many systems in your body which are playing together. and which are so important for you and for your baby. I give you one example. A mother who went through couples of hours of contractions. She has amazing hormone system which is supporting baby's breathing. For example, the cortisol, which helps the lungs of the baby to mature during the first breath. The baby gets this nice strong massage from the uterus, waking it up and being there. There is dopamine, there's adrenaline, there are happy hormones, endorphin involved. So the baby gets this perfect mix on hormones, which prepares the baby, even if it ends at a C-section later on. And I think the recovery from a C-section, the question is not was it an emergency C-section or secondary C-section. It's really, if it is something I'm losing control, it's a dangerous situation. I do not feel in control, and it is physical. I lost a lot of blood, or there was something what is out of control, and this is actually can happen if it's I don't know, an elective C-section or secondary C-section or emergency C-section. So the circumstances of the C-section actually what happened during surgery is actually important, and if there are any underlying medical issues, what is the issue, what was the iron level before, and so on and so on. But I think even if a C-section, a VBAC ends in a C-section, there's no failure. And I think actually having these babies going through contraction, also the mother, is something what is very, very good for both of them. And there's just the scientific research is just at the beginning, what is happening during every contraction. And they are so crucial for all the surviving instincts of the babies that there is no failure at the end. And I think what is in this talk now missing, and I would like to throw this out and say it loud, is what is the success rate of the VBAC? And this is actually 60 to 80% have actually successful births afterwards. And 60 to 80% is actually quite a great number. And the knowledge or the feeling I have with my VBAC couple is that the chances to have a successful VBAC are extremely low. And if you look into the number, it's the opposite. So if I'm just saying, if there's no medical case, an underlying case, just, like, I don't know, it was a breach like with Lily or something else. So the numbers are actually positive, and I am open-minded going into this decision. And I think this decision is no decision of being scared of if I have a great team around me, because it can happen anytime that even a normal planned vaginal birth can end up in a C-section. And that's okay, because there's a medical reason, same like for the VBAC. So there's actually, I don't think it's a difficult decision. And to answer your question, I don't think the recovery is more difficult if it's what people say failed VBAC. I don't like this term because there's no failure in that. I think the recovery can be the same like for a planned C-section. So I think the benefit for babies going through some contraction is always beneficial for both, just about the hormonal cocktail they get.
Thank you, Karen. So I think we have a very good overview already. The only little thing in the back of my mind that still has a little bit small question marks is are VBAC labors or like how are VBAC labors different from other labors? Because Karen, you mentioned in the beginning there's a little bit of lack for antenatal classes for parents that are preparing specifically for VBAC. So what exactly is so different about it? Is it the monitoring or is it something else? So Dr. Grace, if you could maybe answer this, and if or Karen, if you want to say something about that as well, it would be really helpful.
Grace.
Okay, yeah, let me start then. Right, I think for the VBAC, there are a few things that I always like to reiterate is that, like a normal vaginal birth, you can have medication for pain relief, all right, if you need. So do not let anybody tell you that you're not allowed an epidural. If you need an epidural, if you need your pethidine, if you need your Entonox, if you like to hypnobirth, be my guest. There's no reason why you cannot have the same pain relief That's number one, because some people are afraid of pain, and that's genuine. Um, and what else?
Is
I've
there
lost
any
my
way that
Mhm.
that a VBAC is differently handled or managed than
Okay.
a physiological?
As Karen just mentioned before, is that we would like to monitor the baby's heartbeat, because when people do have that tiny risk, when they do rupture their uterus, there's not a lot of sign. You wouldn't suddenly go, ow, or you wouldn't, you can't notice it. But one of the signs that we look out for as doctors is the heart tracing, the monitor on the heart, on the CTG, and also the contraction pattern changes as well. And then it's later that the mother body responds with high blood pressure, or pulse rate changes, or the blood pressure changes. So it is important for us as providers to have monitoring of your baby to be safe for you. And it's a reassurance for you, and it's a reassurance for us. And these days, certainly in Matilda, where we have wireless fetal monitors, you can walk around with it. You're not hooked onto the bed, and you can still squat. I'm sure you remember, squat next to your bed if you want to give birth, or you can be on your
You
side.
use the bathtub as well.
Yeah,
Yes,
yeah,
just
yeah, 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 yeah.
So, Karen, the one thing that stood out for me was you would leave to go to the hospital sooner. But is there anything
yes.
else you would say that you would do differently as a midwife, accompanying a VBAC than any other?
I think the preparation of the couple is a little bit different. So just like mentioning the C-section is standing in the room like for every other birth, what is quite normal, and preparing what was could be better this time, what was not maybe handled perfectly, and the I don't know, depends who is supporting the birth. Usually, the choice of an oxytocin, if the contractions are not strong enough, is not there. So we do not, play all our tricks in supporting the vaginal birth or pushing through the natural birth because there was a C-section before. So it might happen that the decision for, okay, maybe let's discuss the option of a C-section. It's not, even if it's called, unfortunately, in Hong Kong, emergency C-section, it's not a life-threatening decision. It's sort of, okay, we can wait another 1 or 2 hours, but actually there's no progress. Or, we do not have many options now, starting with a Synto drip or giving additional oxytocin. So we are a little bit more careful. So we treat the woman like a raw egg. We observe her more. We make sure the baby is okay. So we are a little bit more careful in, yes, observing all the parameters, and yes, discussing if something is going to happen. But again, this word emergency C-section is just standing in a room because the name is not the best name. And it always, people connect something, oh, the baby is in a distress, something's going to happen. This is least likely. This is mostly that it's no progress anymore. We're here for so many time. The cervix is still 3 centimeters, 4 centimeters. And, it's also a mental thing. This is why I think antenatal classes for VBAC are so important, because, if you experience, an unsuccessful vaginal birth, which end up in a C-section, and you do not understand why this happened, and there's not really a medical reason for it. It just opened up to 5 centimeters, and then it was a stop, and nothing progressed anymore. And if I have this in my body and in my mind, and I enter with my second baby childbirth into the hospital, oh, this is exactly how it was last time. I have the same sensation. And then people constantly connect their not perfect experience from the first baby with the current situation. And this is something what they need to overcome. This is why it is so important to understanding and accepting why was the C-section important for the first time. And I can let go on it. And this is now a new situation. And I need to be open-minded and completely trustful to all my support team, because your body will play tricks. You see maybe the same midwife, she was there last time. Oh my God, it will end up in the same way. Or this was the labor room too. I remember so well. So this is also negative, and this can pull you back into your, I don't know, we are here now, we are waiting for your baby. Baby is going to come, and we are positive about the whole thing. And if it comes different, it will also be a positive birth experience. And there's not like this is a good birth experience because it went this way, and this is a bad birth experience. A bad birth experience is if I'm traumatized, if I lose the trust in my birth team while I'm in labor. This is traumatizing women. I don't know if this is decision right or wrong. This can happen, and this is very, very bad, but this is the reason why a birth is not good or bad, and not because it was a C-section or it was a failed VBAC or it was a VBAC or whatever it is. So this emotional and mental connect and the mindset is so important to be open-minded. And this is why I think the antenatal class, which also I criticize sometimes in Hong Kong, because they are only going through, it is only if it's completely natural, and if there is, I don't need to be a vacuum birth or a venous birth or any other intervention, then it's already a bad experience. I completely don't like that. And I think we need to talk in antenatal classes, this and this and this, but these are medical decisions. This is not my decision, not as a midwife and not as a parent, because I trust my doctor. Otherwise, sorry to say so, then I stay at home. And what I don't think is what we want, because every baby's life is precious, and we're happy to have medical support if we need it. And I think this is something what is important. Yes, I think Lily has a question.
Yes, Lily.
Yes. No, but I didn't want to interrupt. I have a question. Does the age of the mother play any role in if it's going to be a successful VBAC or not? Like, does that have anything to do with that? Especially if it's like an older mom going on the second round or third round of having a baby and trying a VBAC.
Older mom, this sounds so depressing.
Yeah,
Lily.
I know, but you know,
I don't like
some
it.
doctors say, yeah, I know, but sometimes doctors say like 35, you're like old mom.
Geriatric.
Please
Blow the
don't say
birthday
anything
candle,
about older mom. I don't like
Yeah,
older
yeah.
There's no such thing, I think.
Yeah.
No, because that older mum is a medical term that we like to use because we want to categorize in the olden days who's going to go for amnio and who's not, or who is at more risk of Down syndrome and so on. So when we look at older mum, I think your question is, does it matter for a VBAC? I don't think so. I really don't think so. The matter is you got pregnant. And
Okay.
once you're able to get pregnant, you should be able to get it out.
So like no doctor can say, oh, because of your age, you shouldn't do this.
I don't think age is contraindicated for VBAC at
Okay.
all. You need to trust your body that you're able to do it. I mean, if I am so old that I can't get pregnant, that's different. If I was a 70-year-old and I'm a surrogate mother and going through a vaginal delivery, I'm not too sure, right? That's a bit different. That's a very artificial situation. But I think if you got pregnant on your own and you're able to carry that baby, yeah, right?
Mhm.
Mm.
Okay.
Hey,
No.
everyone, we've reached 1 hour.
Yes.
Thank you so much. Is there anything on your mind that you feel like you want to say, Dr. Grace or Karin, that hasn't been said and you want to leave our listeners with? Otherwise, I'm going to wrap up. Thank you so much for everyone to join us today. And as Karin already said, we will have a VBAC positive birth story in 2 weeks. So we will keep you posted on our Instagram page and on our WhatsApp group. And thank you again so much to Dr. Grace for joining us today. And yeah, good night, everyone.
Good
And see you
night.
soon. Bye bye. Thank you.
Bye.
Bye.